Started. All right, welcome everyone, virtually and in person. These are the easiest introductions. It's yet again my pleasure to introduce today's Grand Round speaker. Dr. Surani attended medical school at Dow Medical College in Pakistan before doing his medicine residency at St. Agnes in Baltimore. And then we were lucky enough to get him to move to Milwaukee, where he was a hospitalist here at Froedtert and MCW until becoming an endocrine fellow, where he is now in his second year and excelling, helping me write a review of adrenal insufficiency that's published. So yay. So that's great. He's also a diplomat of the American Board of Lifestyle Medicine and has interest in lifestyle to manage endocrinopathies such as obesity. And today is going to be talking about sick euthyroid syndrome. So Asif, it's all yours.
So firstly, thank you so much, everyone, joining here online. Before I start, I just want to thank all my mentors, my attending, the faculty for all your teaching and support. I don't think I would have done this Grand Rounds without your teaching and your mentorship, so thank you so much for that. So about today's topic, it's an interesting topic because we'll be talking about the sick euthyroid syndrome, a syndrome with different phases. And we're going to see how this thyroid responds in a critical care condition. Is it a sick thyroid, or is it the thyroid which is trying to defend the body? So we're going to talk about how the sick euthyroid syndrome is and what are the other implications and a lot more about that. Before I start, just a formality, I don't have any disclosure. I'm just a fellow. Maybe in the future I might have, but for now, no disclosures as such. But I do have some disclaimers. My first disclaimer is that this presentation is by no means a systemic review. So there could be some trials, some studies that I have skipped. So my pardon for that. And of course, medical literature is ever evolving. So there might be new trial published after the last week I'm done with this presentation. So there might be some new data which is not included in the study. The second thing is my own personal experience with sick euthyroid syndrome is a little limited. Means as a hospitalist, I have managed several sick patients and those who were on the floors. But in general, couple patients here and there. So just want to put it out there. And thirdly, means I'm a lifelong learner. I would appreciate if you have any insights and thoughts about managing this complex condition. So with that, we're going to do some anonymous poll today. The reason for this anonymous poll is just to introduce you to the topic. And again, it's anonymous. And it will be introducing us to the various section of our talk. And it's just to have a little bit tidbit of humor here and there. So just with that, so I'll put my question here up on board. So there are three ways to get participated in this poll. You can click you can do the QR code, or you can join by web, or you can send me a text message. So the first question is, have you managed a patient with sick euthyroid syndrome? And A, yes, and I heroically resisted the urge to fix those labs. B, no, I hope I don't. It sounds complicated, and I will say yes, it could be complicated. And number third, is the thyroid really sick or just caught in the crossfire of critical illness? So I'll give it a moment. We do have a couple polls. It's 50-50 for A and C. If our online participants can join. If you have issue, let me know, but you can just simply scan and the QR code. So we'll give it 30 more seconds. Oh, so now more and more is going into option C. Now A caught up. Okay. So we are tied between A and C. So with that, let us come to our typical objective and case presentation. So whenever we got such consults for sick euthyroid, a typical setting is there is a critical care patient who is typically on a mechanical ventilation or who is on a pressor support or other organ support. Because they are too sick, because their blood pressures are not improving, they are getting hypothermic as such. So a lab is checked, and these are typically the thyroid lab, which is checked as part of the whole workup. Um, Typically, we see low T4, low T3, low TSH, and there's a typical lab that they see. And right away, an endocrinology consult is triggered. And the question always comes that the TSH, T3, and T4 is low. Could it be like a central hypothyroidism, or should we pursue a brain MRI? Or the patient pressures are not improving. Can we give some IV levothyroxine and maybe that would help? So typically, that the question on that's a typical case presentation of the sick euthyroid consists of. So in today's talk, we're going to start with the prevalence and risk factors of sick euthyroid. And we're also going to talk about significance or how to interpret and what are the consequences of it. We're going to spend some time on pathophysiology and mechanism of abnormal thyroid lab results. And lastly, a big chunk of this talk would be dedicated to treatment or no treatment or what could be the possible future directions. So just spoiler alert, I mean, you might be a little disappointed with the treatment section here. But with that introduction, let's dive into our introduction here. So sick euthyroid, I like calling it sick euthyroid because it says that patient is sicker and because the TSH is low, so it's a euthyroid state, not a hypothyroid state. It's also called a low T3 syndrome because that T3 is typically lower in such patient population. And a more scientific terminology nowadays is non-thyroidal illness syndrome, NTIS that we call. The reported prevalence is ranging up to 38 to 70%. So almost two-thirds of the patient, especially in the critical care setting, could have this condition. So it's very common, very prevalent. I'm happy that not every critical care patient gets a thyroid check because then our consult volume will increase like multiple fold. Um, and it has been seen in variety of illnesses like you name it, infection, trauma, MI, surgery, burns, all the various illnesses that we typically encounter, we can see NTIS in such patients. Interestingly, the degree of NTIS correlates with the severity of an illness. So more sicker the patient, being on mechanical support, mechanical ventilation, pressure support, organ support, they have more severe NTIS. And one thing that I always ask to myself as a hospitalist is NTIS only limited to a very sicker patient, or can a flow patient who is not as critically ill can have NTIS? And the answer is yes, they can have NTIS. And it has been shown in conditions like heart failure, kidney disease, liver disease, HIV. And essentially, the bottom line is that the more severe the illness, the more severe the NTIS will be. So this is a little introduction of our sick euthyroid syndrome. Now coming to the pathophysiology. So as we know, thyroid is regulated by several organs, namely the hypothalamus and all the way till the cellular level. So several things goes wrong to manifest this NTIS to cause this low TSH, low T3, and low T4. So there is a role of hypothalamus pituitary axis. There is a role for hormone transport. There is this very notorious deiodinases metabolism pathway that has been recently debunked, so we'll talk about it. And even at a cellular level, there are several changes that happen that lead to the manifestation of NTIS. So we'll try to do it in a more chronological order, means this is by no means a scientifically proven thing that happens in this way, but this is by reading the literature, this is my best guess that this happens in this way. So the first thing that could be involved is the role of the deiodinases. So just to put us to speed, there are three deiodinases, the D1, D2, and D3. D1 and D2 deiodinases basically activate thyroid hormone. They are the activating hormone and they convert the T4 to T3. So it kind of activates the thyroid hormone. And the D3 is an inactivating deiodinases. It inactivates thyroid hormone by making a reverse T3. The difference between D1 and D2 is that D1 is predominantly in the liver. It's more along the cytoplasmic membrane. So the conversion from T4 to T3 is predominantly exported out in the plasma, while D2 is in predominantly in the muscle and it's more endocytoplasmic, so it's more intracellularly. So typically we were taught as a medical student or resident that the D1 and D2 goes down, and that's why the T3 levels goes down, and the D3 levels, which is expressed in, again, the liver, muscle, and kidney, they go up. So that's why you have a low T3 because the D1 and D2 are down regulated, and elevated reverse T3 because D3 is up regulated. But lately, this theory has been challenged, and we are not sure if this is the first or the mechanism that's predominantly playing a role. Why is that? Because there are 3 points in this literature that was highlighted. Number one, they had a D1 and D2 knockout mice. So those mice who do not have D1 and D2 when they were injected lipopolysaccharide, they have the similar feature of the low T3, low T4. So not sure if that enzyme lower was the predominant pathway that caused this hormone reduction. Second, when they checked the thyroid level, the T3 and T4 levels goes down first, and then the expression of D1 and D2 goes down. So the levels are starting to drop even before the D1 and D2 expression is lowered. And third, they have seen that the D2 expression is more in the muscle. So all of this just makes it a little complicated, but that predominant concept of D1, D2 going down, D3 going up, and that's why reverse T3 going up has been recently challenged. And I'm not sure if that's the predominant cause of causing the low T3, T4, and TSH. Then the second component is the hormone transport. As we know, thyroid hormone is bound to thyroid binding globulin and transthyretin. Both are a negative phase reactant. So they are made by the liver, and in acute inflammatory setting, they goes down. So that's why when there is less binding protein, the hormone is more, the free pool of hormone is more, leading to more clearance from the plasma. Interestingly, in sicker patients, elevated free fatty acids and bilirubin impair the thyroid hormone binding to those proteins. And the drugs like we commonly give in ICU, like Lasix, can also compete the binding. And all in all, there is reduced binding of the thyroid hormone to those proteins, leading to increased thyroid hormone clearance and more subject to metabolism. So that's the another thing that might happen early on that lead to decrease in the levels of the hormone. Then there is this notorious hypothalamic pituitary axis. I think it comes a little later in the clinical illness, and it's basically the predominant cause of reduction of the TSH. So we know that critical care illness results in the lower TSH amplitude and the nocturnal surge. And it could be from the medications like high-dose steroids, dopamine, dobutamine, all that acts on the pituitary gland and suppresses TSH. Also, some cytokines, inflammatory marker, they act on the pituitary gland and they suppress TSH. Now, lately, more and more, we have realized that there is a role of the hypothalamus or TRH in it as well. And there is a study which I'll quote later, but when there is a starvation from critical illness, the leptin in the body gets low, and that somehow causes the hypothalamus to make lesser TRH and then consequently lesser TSH. So that might be a pathway. And more, the post-mortem analysis, they have seen that in a patient in around the hypothalamus in the tanocytes, there is more D2 expression, and we know that D2 converts T4 to T3, so there is more local T3 which suppresses hypothalamus and which causes low TRH and then consequently low TSH. So these are the possible mechanisms in the pituitary or hypothalamus that might be responsible. One interesting thing, I would point out that the TSH is lower but should never be undetectable. With the more newer and newer assay that we have, it should never be undetectable. The typical range is 0.08 to 0.4. So that is what the TSH should be, but it should not be undetectable. Lastly, we know that at a cellular level, there is modified entry of thyroid hormone. So we know thyroid hormone works in the nucleus, and it needs a transporter to get intracellularly. We have seen that in the multiple trials, in vitro trials, that the transporters are expressed more and more. So there is more transporter expressed, but despite that, the intracellular level of thyroid hormone is very low. So there is a question that maybe there is some conformational changes in those transporters that lead to reduction in the thyroid transport across the membrane, possibly. And maybe in the nucleus, there is reduction in the thyroid hormone receptor. So all in all, we get a lower thyroid hormone through binding, through pituitary, and even going all the way to a cellular level. And the mystery does not stop here. The question is, are these testing really accurate? Are the free T3, free T4 that we are measuring are really accurate? And probably not. This is a little older study that was done by Welch et al. And I'll just orient you to the slide. So they have checked multiple free T4, free T3, the total T3, total T4 through both the conventional immunoassay and the LCMS. And that LCMS was through the ultrafiltration, not the equilibrium dialysis, but the ultrafiltration. The vertical lines are the lower and upper limit of the immunoassay, and the horizontal lines are the lower and upper limit of the LCMS. So the first thing from this chart, we can see that the total T3 and total T4 correlates very nicely. The level by immunoassay and LCMS correlate nicely, and they are mostly on the lower side, which is not unexpected because of the lower binding globulin. But when it comes to the free T4, now free T3, sorry, now the discrepancy starts. If you can see, most of the level by the immunoassay is on the low, but by the LCMS is on the low normal range. So T3 is low by immunoassay, but not as low by the LCMS. And interestingly, the free T4 is lower by the immunoassay, but if you see by the LCMS, it's actually high. So we are not even sure that if those low T3, low T4, that changes that happen are actually real. And they say that there are several interference by the critical care illness in the serum that cause these abnormal results and inconsistency between immunoassay and LCMS. So that's why they say that in critical care illness, we can primarily rely on the total T3, T4 level because they are more reflective and consistent, or by the equilibrium dialysis again, which is not as practical because that's a reference lab and will take several days before it comes back, and by the time the patient won't benefit from all this discussion. So just to summarize, we have the NTIS varies with the severity. Consistently, we see low total T4 and low total T3. The TSH is lower. The free T4 can be higher, but lower in more severe illness. The T3 is also low normal or on the lower side, and the reverse T3 is elevated. So that is what typically that we see in terms of pathophysiology that happens. So the question is why all these changes happen and what's the cause that is driving these changes? And essentially, as I mentioned, the cytokine, inflammatory markers, increased endogenous cortisol secretion, and drugs like dopamine, dexamethasone, and even the bacterial lipopolysaccharide, all these can result in effect at several levels that can lead to these thyroid hormone changes. So with that, we'll come to our second anonymous poll question. If you have already scanned the QR code, you can see it when I change the question here. So the question is, sick euthyroid syndrome is best understood as, and whoever is new, they can just scan the QR code, you can scan it, and then you can participate in the poll. It's an adaptive response, the body way of saying, let's conserve this, let's conserve energy and survive this mess. Or it's a maladaptive response, just another thing going wrong when everything else is going wrong. Or all of the above, none of the above, just like any other plot twist in medicine. So we have more things as adaptive, and now the poll is changing, and now like most of people say it could be an adaptive response, and some say all of the above, none of the above. But nobody feels it's maladaptive. Okay. So let's get to our second part of this talk, which is the consequences. Is it an adaptive response or is it a maladaptive response? Is the thyroid just being in the crossfire, or is it actually protective, or is the thyroid actually a villain here and that's causing all the messed up hormones that is happening? So let's talk about the consequences. So consequence number one, we'll focus on the positive side, the adaptive response first. So it could be an adaptive attempt to reduce energy expenditure. And I will cite an ICU study, and I know you will be thinking why I'm citing this parenteral nutrition study, but we'll get to our point. So there is a study in which they randomized 4,600 patients to an early parenteral nutrition, those who are getting the TPN, and those who are getting TPN after 8th day. And they have seen that those patients who were fasted early on or got TPN later were actually had fewer complications like reduced infection, muscle weakness, and if we see the graph, the late initiation of TPN have favorable outcome in terms of ICU discharge, alive from the ICU, discharge from the hospital, alive from the hospital. So fasting early on is actually protective. What does it have to do with thyroid? Because when they checked these patients who were fasted early on, they noticed that their TSH is low, their T4 is low, T3 is low, and reverse T3 is high. So a typical NTIS picture, and as we discussed in the pathophysiology, fasting causes lower leptin, which causes lower TRH. So they feel that the lower thyroid hormone is actually a adaptive attempt in like happen in the setting of fasting that is actually protective. Not only this, there was another sub-analysis in which they did complex statistical equation, which I could not understand. But essentially, what the study showed that these patients who were fasted and who had these low T4, TSH, and T3, this is actually an independent predictor of survival and improved outcome in a multivariate analysis. So those patients who are fasting, yes, but who are fasting and have these lower thyroid hormones are actually having more benefit compared to fasting and having a higher thyroid hormone. So potentially, maybe the lower thyroid hormone is beneficial because it reduces metabolic rate, catabolism, and all those good things. So potentially, it is adaptive. Then let me give you another argument. There is improvement in the regulation of immune function. So D2 and D3 not only expressed in liver, kidney, and muscle, they are also expressed by macrophages and cytokine. And it has been seen that it's very essential for their cytokine production and phagocytosis. And those knockout mice who did not have those expression of D2, D3 were unable to make cytokine and have phagocytosis. And interestingly, there is increased D3 expression in granulocyte. As we know, D3 is an inactivating hormone. It causes reverse T3. So basically, this process liberates iodine, and iodine is helpful in the bactericidal effect. So maybe it's the body's way to conserve iodine and use it as a bactericidal effect, potentially, and that's why could this be an adaptive response? Let me give you one more argument here that there are several various expression of D2 and D3 in the lungs. There is increased D2 expression in the muscle. As we know, there is increased D2 expression. We don't know. Maybe this is the beneficial effect in which the body is trying to protect these specific organs, and that's why it's lowering the or increasing the thyroid hormone. We don't know, but this NTIS may have some unknown benefit that can cause a protective, that can, I think, yeah. I'm so sorry for that. Um, and maybe the metabolism is reduced from lower thyroid hormone, and that's why it's protective. So yeah, thyroid hormone lower could be a protective response and could be an adaptive response, and those who selected that are right. But now let me tell you how it is maladaptive, and we're gonna see other three arguments when I'll try to convince you that it is a maladaptive response. Number one is association with mortality. We know that the sicker the patient is, the lower and the severe the thyroid hormone changes are. And they have seen in a study that those patients who have a total T4 less than 40 are having a sensitivity of 75% and specificity of 80% in predicting mortality. So patients who have severe low T4, severe low T3 are more at risk of dying. So could it be that patient is so sicker and that's why the thyroid hormone is low, or the thyroid hormone is low, which increases their risk of mortality? So there is an association of mortality. Likewise, low T3 is a strong predictor of mortality in patients with heart disease. And time and again, in several articles which I have quoted down, the degree of NTIs is independent predictor of survival. The more severe the degree is, the worse in the survival. The lesser the degree is, the better the survival. So maybe NTIs is a maladaptive response, and that's why the patient who have severe low T3 and T4 have more chances to have adverse outcome and increased mortality, potentially. The other thing, we know that ICU patients have several unexplained symptoms like altered mental status, depressed myocardial function, hypothermia, muscle weakness, you name it. they have it, and they will all could be attributed to a low thyroid hormone. So maybe in critical care setting, the low thyroid hormone potentially is maladaptive because that all the symptoms that a prolonged critical care illness patient have is essentially attributed to a low thyroid hormone state. So maybe it's a maladaptive response. And to prove this, as we know that in the recovery of the NTIS, the TSH actually rebounds before getting back to normal. So maybe this rebound is actually the brain telling that I am hypothyroid, and that's why the brain is sensing and making more TSH at the recovery, maybe indicating that I was hypothyroid all along and you never picked it. So potentially it could be a maladaptive response. So at this time, we are not too sure that if it's a protective response or if it's a maladaptive response. Maybe it's more dependent on the timeline. Maybe early on is protective, like the feeding thing we discussed, that because of the starvation early on, it's a protective early on. And maybe as the critical care is prolonged, maybe it becomes maladaptive, and that leads to the unexplained symptoms of low thyroid hormone. Potentially. So we are still not sure, but it has those two phases that we are not able to tease out which phase the thyroid will show us. So which brings us to our last anonymous poll question. Um, and it introduces to our last part of the talk, which is the treatment. The treatment of sick euthyroid syndrome is cautiously giving levothyroxine, because a little bit of levothyroxine can't hurt, right? Or can it? Um, Never give levothyroxine because you're just adding fuel to the fire, and you don't want to start that fire and that AFib and everything. That how will you manage it? Or no clear answer. You're just like solving the Rubik's cube, like we seen in the Instagram video. They solve it while their eyes closed and they do it, and maybe it's that. So most of us feel that is C, and some people are very against levothyroxine. There's nobody in favor of levothyroxine. Maybe then I have to do some convincing here. But we'll see. But most of us feel that there is no clear answer here. So let's see what actually the data shows and what actually the literature suggests. So in our fellowship and in our training, we are cited two bigger studies, and one of that is by Brent and Hirschman, and it was done in 1986. This was, and to the best of my knowledge, the first study that have actually randomized patient, the critical care patient, and actually given levothyroxine. So they had 22 patients, 12 controls, 11 intervention, a very small sample, as you can see. An intervention group received 1.5 microgram of IV levothyroxine daily for 14 days. So 1.5 microgram is actually a standard replacement dose, and that of IV, because IV is more potent, so that's a very high dose of levothyroxine, and that also for 14 days. And what did they study, and what the study showed, that when they give such high doses, the T4 levels promptly and return to the normal in the treatment group, but the T3 levels did not improve. And of course, if you give more T4, the brain will suppress the TSH, so TSH levels are decreased. And what they have seen, that the mortality was equal in both the groups, 75% versus 73%. And as you can see, 75% ICU mortality back in 1986. So that's already a very high mortality. And maybe this study in that setting and with that high doses of levothyroxine might not be applicable, because you already have such a high mortality to begin with. So this study was the first one to show us that potentially there is no benefit in treating with IV levothyroxine. And that is what we were thinking, that why to confound the picture and give IV levo or levothyroxine in general as such. Then the study came in 2000 by Ecker et al. And this study had 59 patients, 31 control, 28 intervention with acute renal failure. So they particularly selected patients with higher creatinine and those with acute renal failure who are about to initiate dialysis as such. And their dose was a very high dose, again, 150 of IV levothyroxine twice a day for 2 days. That's how they did it. And this is what their data suggests. So on the 7th day, those who were treated with levothyroxine, their TSH is low, and that's significant. So of course, giving levothyroxine will suppress the TSH. Their free T4 is marginally better compared to the control, but is not statistically significant. And their T3 levels are actually the same compared to the control. And what the outcome was, and the outcome was especially the mortality. This was the first trial ever which showed that the levothyroxine worsened and increases mortality. And as you can see, 43% patient in the treatment group had mortality compared to 13% in the control group. And from the first trial, we said that there is no benefit. And the second trial by Ecoretil was showing increased mortality. People's and the guidelines were like, no, levothyroxine is bad. Now, let me tell you, this trial has lots of critique. And the first critique was that the 13% mortality in the control group is very debatable because at that time, the author admits that back in those 2000 era, 43% of around 40% mortality was standard. Like first they were 75% and in 2000 they were 40%. So they were also surprised that 13% is not typical for mortality in an ICU setting back at that time. So there is this big question mark that maybe the control group were less sicker, though the Apache score and everything were comparable between the two groups, but that was the biggest critique, that why there is such low mortality in the control group compared to the treatment group. So because of these two studies, we were like focusing more avoiding the levothyroxine therapy. After that, there have been several studies which I'll try to consolidate that happened since then and which have shown mixed results. So let's go over all these studies. I will predominantly include the one which are more randomized controlled trial. So first, I wanted to get your attention to the study population, and I would just highlight how heterogeneous the study population is. We have bypass patient, burn patient, bypass patient, valve surgery patient, a typical patient like an ICU with low T4, and a cardiomyopathy patient. So a very heterogeneous group of patients to begin with. Then the second, I would like to get your attention to the T3 and T4 dosing. Some have used oral T3, some have used IV T3, some have used IV T4, and some have used oral T4 for 3 months. So we have a whole heterogeneous T3 and T4 dosing, and it can range from like something very high or very low. So they are all over the place, suggesting that there is no uniformity in the dosing. And lastly, the outcome they have analyzed is not more so clinically relevant. In some studies, they check the morbidity and mortality, which are more clinically relevant. But in other cases, they check cardiac performance, they check hemodynamic variable, they check the resting metabolic rate and other hemodynamic data. But with all this study, we have seen one thing that I would like to emphasize, that there was no harm detected. There is no mortality or any other adverse outcome that was detected other than the Ecker et al. Study that we discussed earlier. There was some benefit in some study, like there was some improvement in hemodynamic values like cardiac output. There was some improvement in the vasopressor need in the patients with the high-risk valvular disease, but there was no improvement in mortality in which mortality was assessed. So on all these important studies that I have highlighted, we have seen that potentially in cardiac patient or bypass patient or those patients with valvular surgery, there might be some hemodynamic improvement, variable improvement, but there's no improvement in mortality, but there is no mortality as such from giving the therapy. So that makes me a little reassured that that mortality wasn't reproduced. It makes me a little sad that there is no benefit in mortality, but these blips here and there of hemodynamic improvement are a little encouraging, but they are not conclusive that to make us think that we should start giving that pill. One thing I want to highlight about the vasopressor need, in which they said that there is benefit by giving T3 orally in a high-risk valvular disease. When I dissected the study, it's basically the vasopressor need improve on the day 1, but on day 2 it's the same. So don't know how to make about this or what to interfere, get it from the study. Coming to a more meta-analysis, So I've included 2 meta-analyses because the other ones are more pediatric and congenital, which I will exclude because it's beyond the talk or beyond the scope of the study. So did include the cardiac surgery patient, and there's like a bunch of other trials which we have discussed earlier as well, multiple variant of the T3 dosing. And in this meta-analysis, they have shown that the cardiac index have increased reliably in the cardiac surgery patient, and that hemodynamic parameter has improved, but there is no beneficial effect on the mortality that was seen and no increase in mortality that was replicated. More interestingly, in nephrotic syndrome, giving the levothyroxine 20 to 50 microgram per day has actually causes remission of nephrotic syndrome. Not sure how did that happen, but again, it's not a population that's more critically ill and it's not relevant to the talk, but that was an interesting finding. So all in all, we concluded that the association of mortality by Ecker et al. Might not be as significant as we thought early on. There might not be as improvement in mortality, but there are some benefit in cardiac parameters, particularly in patients with cardiovascular surgery. So the question is, why? Why it happens and why there is no benefit when we actually proven that in a cellular level there is hypothyroid, the thyroid hormone could be beneficial. So that brings us to the phase of the illness. Maybe early on, the low thyroid hormone is protective, like in that trial with the later TPN initiation, and maybe in this study, they have given the levothyroxine early on, and that's why it did not show any benefit. Maybe in a more chronic setting or more protracted critical illness, it will show benefit, but we don't have the trial for this. In animal study, the combination of T3, T4, and T3 were unable to bring about the rise in the plasma hormone. It has been shown that if you give more T4, there would be lower T3 and TSH, and if you give more T3, there would be lower T4 and TSH. So we are not able to bring about it. Maybe it comes down to actual cellular level at how individual deiodinases and cellular tissue are responding. And lastly, interestingly, in a postmortem study in a patient who actually received thyroid hormone who was critically ill, when they did a postmortem analysis, the liver had the highest T3 concentration, but none of the other tissue had the T3 concentration. And in other study, the muscle have the highest T3 concentration, but none of the other tissue displayed an actual high rise in concentration. So maybe there is a differential aspect to the thyroid hormone regulation at a tissue-specific level, which lead to the blunting of this response. Then the question comes, how about we bypass the thyroid hormone and we give the actual stimulating hormone like TSH or TRH? Has that been trialed? Yes, it has been trialed. Most of the studies are done in the early 2000 or late 1990s in Belgium, and they have actually given the TRH and the growth hormone releasing peptide, because when they give the TRH only, the T4 and T3 increases, but the reverse T3 also increases. So they had to pair it with the growth hormone releasing hormone to blunt that rise in the reverse T3. Not sure what the mechanism is, but this is what they have shown. And in these studies, they have actually taken patients with protracted clinical illness that was defined as critical care for more than 14 days. So they have actually employed the patient who were at the later part of the illness, and they give varying combination of TRH, growth hormone releasing peptide, and if you can see, they have given a several combination. And in all of this study, they have found that it is beneficial. But if we focus on the main outcome, they have checked the TSH, T3, and T4 level normalization, the IGF level normalization, and actually the catabolism variable. None of that might be clinically relevant, but none of these studies have assessed mortality. Most of these studies included just 20, 30 patients, and it's like a more proof of concept study. So this might be an interesting venture moving forward. I know the TRH is not available here, so that's a moot point, but maybe in the future, giving a TRH later and the growth hormone releasing peptide later in clinical illnesses actually improve the TSH, T3, and T4 level and bring it to a normal level. But we are not sure how it impacts the mortality. The question always comes in mind, has anybody tried the thyrogen, the TSH? Can it be tried? You just give the TSH? It hasn't been tried yet. Nobody has ever employed thyrogen in such setting. It has been employed in a patient with central hypothyroidism for some other reason, and giving thyrogen or TSH improves T4 and T3 level, understandably, but none of that have been verified in a clinical setting. So the question is, where do we stand in 2025, or what should we do now? So at one end, we know that it could be a maladaptive association with mortality, and some of the critical care symptoms are explained by low thyroid. But at other end, it's protective, like at an immune response level, at an adaptive, like energy expenditure level. So I am not sure we have a clear-cut answer. At least we know that it's not as badly related to mortality as was demonstrated, but it has not been actually beneficial in improving mortality. What to do about those cardiac outcomes that we have shown? Not sure. Will it be beneficial in patients with critical illness who have low blood pressure, who have high pressure need? Can the pressure needs come down? Potentially, but it hasn't been tested in a clinical trial. So in 2025, we still have lots of question marks than answers. So what my general approach is, or what I do, if in a critical care setting, if the TSH is high, T4 is low, that could be the primary hypothyroid or recovering NTIS. And in such critical care patient, we always should rule out mixed edema because the TSH level does not correlate with the severity of mixed edema. So such patients should be given levothyroxine if their TSH is not low. The second thing is, if the TSH is actually low, and if it's suppressed, then you should consider like the thyrotoxicosis if the T4 is high. Because as we discussed in NTIS, the TSH should not be undetectable. So having an undetectable TSH in a normal or high T4 should make us think about thyrotoxicosis. And in that case, we should rule out thyrostorm because those are sicker patients having tachycardia, hypothermia, and so on and so forth. And a typical lab like we see low TSH, low T4, NTIS could be likely, and the question mark remains. Giving levothyroxine might harm, not likely, might help potentially, but we are still not sure. So with that, I'm going to end my talk and see if you guys have any comments, suggestions, or thoughts.
So please feel free to unmute or type in the chat for questions. I guess I'll start. Great talk. One interesting thing about all the studies is the dosage of T4 and T3 that they give people. Like the 200 micrograms of T3 a day. The other T4, like you mentioned, I mean, 1.5 micrograms per kilogram. I mean, big doses IV. I don't think there's much literature on reasonable thyroid hormone doses like we would think about giving. Am I mistaken in that?
No, I think you are pretty spot on here. I could not see a very reasonable dosing like 50, 75 or 50 IV. Most of them have gone full force and given like such a high doses, and even for a longer duration, like for 7 days or all the way till 3 months. So there's such an heterogeneity. So I wish there was a trial which had employed reasonable doses and we see the outcome, but now they have very varying doses. Yes.
I mean, 200 of T3 is what, about the equivalent of 600 of T3 of T4?
Yeah.
So it's about 3 times as potent.
Yes.
So.
Yeah, and then I think typically we give like 2.55 or 10, right? And 200 is
200.
pretty.
Great. Oh, Dr. had a question here in the chat box. Is there any overlap of these patients with CIRCI, CI? Herschel, you want to give us the abbreviations? That's critical illness related something.
Well, Asif knows what it is. A critical illness related corticosteroid insufficiency.
Yes.
CIRCI.
Yes. Means that's a very valid question, and in my talk when I was preparing, I didn't specifically include those trials, but typically I have seen that in those patients who were actually given the TRH and the growth hormone releasing peptide, those have that improvement in the cortisol and ACTH levels. So I'm not too sure that those, I haven't seen in the trial that they have studied in that way to see, but in those, they have given the trophic hormones. There, they have shown improvement in those cortisol.
Ty, can I ask a question?
Yeah, please, Joe.
So, Asif, that was a great talk. So, could you even get TRH if you wanted to give it?
No, in USA, it's not commercially available. I mean, those studies were in Belgium, so I don't think we can.
Yeah, I don't think it's been available for 20 plus years.
That's what I thought. Thanks.
I think what Dr. Herschel was referring to 15 years ago, there was a lot of excitement about critical illness, corticosteroid deficiency, when they had totally different levels for abnormal cosentropin steam test. And there was excitement. I mean, I probably remember like for a few years when a lot of patients received a lot of steroids. And then, you know, their follow-up study kind of didn't show much of the benefit. So it kind of phased out pretty quickly, but there was a lot of excitement. And I think that's what would be curious to know if those patients that develop this totally different bucket, not the actual adrenal insufficiency, but however was defined critical illness, corticosteroid deficiency, which is a separate entity, if they had coexistent. Did I kind of get it? What you were asking?
We did a study on this. We did a study on this. It's a real mishmash. You know, you guys know I did several studies in the ICU at St. Luke's, and didn't matter what I said, they gave the steroids anyway. Doesn't matter what the guidelines say, they give the steroids. Doesn't matter what the ACTH stim test is, they give the steroids. I mean, it was really quite remarkable. But there's some really nice articles from Griet Vanderberg in Belgium, where it is a real phenomenon. Is it clinically significant? I think is the point you're getting at. What's so interesting is it really has to do with cortisol metabolism more than anything else. But I mean, I did a study. I say, why are you doing all these ACTH stim tests when the results don't influence what you do with the patient? And everybody sort of just shrugged. So I gave up.
Asif, I have a question. So if a provider was giving T3 to a critically ill patient, what would you say as an endocrinologist? Like based on the studies you showed, is that like maybe okay because the hemodynamics will improve, or?
I mean, number one is the dose. What dose they are giving it?
Like 20.
Q12, yeah.
Yeah, Q12, which I've seen people do actually sometimes.
Means I would say if it's a last-ditch effort to support the system potentially, but there has been only shown improvement in hemodynamic parameters in a surgical patient who are undergoing CABG or a valvular surgery. Time and again, it has shown that T3 improves cardiac output and decreases systemic resistance. So it can go both ways. If they feel like the cardiac output is depressed and they feel like it should be given, can try. At least we know that the mortality association is not as high as it was demonstrated. But I wouldn't fault them if it was the last drug they want to give it to a patient who's crashing. So, yeah.
Could you go back to your T3 slide? I mean, if people are going to do that, I mean, should they be giving T3 in these doses? I mean that's where the data would be,
I
right?
guess if you do it, you might as well mean it, but the whole,
I mean, in elective cardiac bypass,
right?
You know, 125 of T3 a day or a week.
That's all we're saying. Increase my cardiac oxygen demand. I don't know how you fit that in.
Yes. And then most of these study the hemodynamic data. I'm not sure if it is important, a clinical relevant point as such in a long perspective, in which we typically look into mortality. So your pressure need might come down for a day or two, but what does that mean? Does it buy you time? Then otherwise, what does that entail?
I want to add one more question. So, as Dr. Raff was mentioning about the thyroid hormone metabolizing the cortisol levels. So, for example, if we are called for a euthyroid sick patient and the free T4 is significantly okay, but the TSH is high, and you're thinking that the patient might be having hypothyroid, would you check cortisol level at that time before giving levothyroxine? Because what if you give levothyroxine and then patient has an underlying AI and you worsen that?
I mean, if the TSH is high and the free T4 is on a normal range?
No normal.
Because there could be either the patient is primary hypothyroid or if it's a recovering NTI, so that setting is important. Again, I would take a whole clinical picture and what's the purpose of giving the levothyroxine, because as we know in the critical care, the TSH value can go up and down and the SS does not get reliable. So if there is a specific need and if there is a deficiency, then we might look into the cortisol and replenish that first, and if we think that way. But just like going based on the labs, it's challenging based on the whole clinical context.
Okay.
Yeah.
Any other questions?
Yeah, quick question. I have a really quick question, if you guys can hear me.
Yeah.
When they did these studies with the benefits of the levothyroxine supplementation or thyroid supplementation, did they specify like what kind of phase of the sick euthyroid kind of thing is, like TSH is low, T4 is low, T3 is low, or they did not specify?
So most of the study which employed the levothyroxine actually give it early on, right at the start of the event. Like if it's a bypass surgery, if it's like ICU patients, they just give it right away. They did check the pre-treatment TSH, T4, and T3, and they were lower, suggesting NTIS. But especially in the bypass patient surgery, they haven't measured that outcome in patient with. In this study, ICU patient with low T4, that was when it was only checked. But other studies simply give it at the start of the procedure or at the start of the anesthesia, and then check the thyroid hormone later on, and it's trended.
I see. Thank you so much. You can guys clap again. That's fine.
I had a quick question. Great talk. I was curious if in any of your research you saw patients with NTIS in a failure to thrive type of situation, and if they had any interventions. From what I've seen, it tends to be more case reports, but I don't know if there's any formalized studies on this.
Yeah, I mean, I did not come across that population. The only population I came across was those protracted clinical illness who last more than 14 days. In that, where they employed the TRH and growth hormone releasing peptide. But as such, I haven't encountered like failure to thrive and giving levothyroxine. Maybe it's in the case report. Maybe it did not come in during my literature search, but not that I have seen that as a studied population with a randomized trial.
Thank you.
Thank you so much. Thank you.